So welcome to today's talk in our early psychosis training series. I'll be discussing therapeutic approaches for addressing positive symptoms of psychosis. And as I mentioned, this is brought to you by the STEP Learning Collaborative, which is a collaboration between the STEP program at Yale and Connecticut, DEMIS, and DCF. And I have no conflicts of interest to disclose. Before we dive into all the different therapeutic approaches I want to cover today, just a quick reminder of what we're focusing on. So we're talking about positive symptoms and how to approach them. There's certainly ways to therapeutically approach negative symptoms. I just can't cover them in today's talk. So as a reminder, positive symptoms of psychosis would be things that are kind of extra or in addition to or a distortion from an individual's typical functioning, perception, or behavior. So these are our most common, most recognizable symptoms of psychosis. They include things such as hallucinations, which can impact any sensory modality, illusions or fixed false beliefs, which can also be persecutory in nature, making them paranoia. It can also include bizarre or disorganized behavior or communication. And it's important to know that with psychosis, there's often limited insight, and that's an inherent part of the illness, meaning that folks often don't recognize, have the awareness that what they're experiencing isn't happening for other people in their environment. And the kind of continuous lack of awareness of this is called ansoagnosia. And I just wanted to give a little shout out, Dr. Xavier Amador and the LEAP Institute, if folks want to look into some additional strategies about addressing ansoagnosia, which would be relevant to both providers and family members. So now that we kind of have set the stage for what symptoms that we want to be targeting, I just want to give you a brief clinical scenario to hold in mind as I'm talking about some therapeutic approaches. I'll reference it throughout, and particularly in the more in-depth CBTP formulation that I'll share with you at the end of the talk. So imagine in your clinic, you're working with a 20-year-old client who has a history of psychosis, and they're presenting to your outpatient appointment complaining that I'm really stressed out. They describe an increase in voices who are shouting negative things at them. They also feel like their classmates are plotting against them. This individual is not currently on medication and states that they don't want to take any, which is a common occurrence. They also describe that they're smoking cannabis to help with the stress related to these experiences. Textually, they're currently living with their family and they're enrolled in school. So you've worked with this client for several months and you're aware of their goal to stay in school without the need for another medical leave, which they had previously taken. I won't necessarily reference all the specifics of this scenario, but I think it's one that for those of us who work regularly with individuals, young people experiencing psychosis, it's not an unfamiliar scenario. And so once you've, assessed for safety and risk, and maybe you've checked like, hey, did you get some cannabis from a different supplier this week that may be resulting in this uptick, and kind of check all those boxes, they're safe, they're still unwilling to engage with antipsychotic medications. You're like, okay, how am I going to address this therapeutically? And so this is just a quick review of the kind of step elements of care or the components that make up the coordinated specialty care model. So again, today we're going to be focusing on how to address these experiences through psychotherapy modalities. Of course, there's various other ways and parts of the intervention that we could engage in for folks. So as I mentioned, I'm going to provide an overview of different therapeutic approaches, and then we'll go more in depth to that CBTP formulation. It's important to keep in mind, and I'll reference throughout, that any intervention, I think with a young person with psychosis, is going to be recovery phase specific. So we've got different phases of recovery. We've got kind of an acute phase when someone's actively experiencing symptoms of psychosis, and you're really just focused on kind of distress tolerance type skills and engagement strategies, keeping them safe. And then there's more of a maintenance phase where you're able to kind of work more on goals and have regular appointments and folks are engaging. And then you've got the kind of more recovery phase where there might be remission of their symptoms and they're really continuing to actively work on goals. It's important to recognize that throughout anyone's course of treatment or course of illness and recovery, it's not uncommon to cycle in and out of these phases. It's not linear, but often someone might come to you for the first time in the acute phase, or they're coming out of an inpatient hospitalization, just getting out of the acute phase. But folks do have relapses of symptoms. And so you flex these interventions throughout your time working with someone. And so what might be applicable one week, some more intensive therapeutic work when we're in the recovery phase, we might swing back to just some grounding and distress tolerance the next week if we see an exacerbation of symptoms. So it's important as a provider to really be flexible and kind of constantly keeping in mind where the person in front of you is at. Here is the outline of some of the different categories of interventions, and I call them individual psychotherapy practices, but they can certainly be delivered in group modalities as well, that I'm going to go over today. And this is just how we've organized them at STEP, and they're based on different evidence-based psychotherapies and approaches. But so I want to start with what we usually start with: engagement and developing a shared understanding of experiences and goals. And so with this, I think of a couple main bullet points: a befriending approach, which I'll talk about. I like to really use this stress bucket analogy, which I'll walk through. And then I think it's also important to talk with your client about values or goal setting, right? This is basic stuff that we would use for anyone, I think, coming into therapy, regardless of their diagnosis. And that is a point that I want to kind of hammer home today, that yes, we're going to be talking about how to flex these interventions specifically for individuals experiencing positive symptoms of psychosis. But for those of you that are community providers and are not specializing in psychosis, I hope that you can come away with this with some confidence in your existing skills and knowledge of different therapeutic interventions that are kind of transdiagnostic. So to start with this engagement piece, strategies for engagement, particularly with young folks with psychosis, but also adolescents and young adults in general, it's important to be flexible. Be flexible as much as you can within the constraints of your organization, your system, trying to be flexible on timing of sessions as much as you can. Folks, depending on what stage they're in or how much they can pay attention or tolerate or feel comfortable, you might need to make shorter, more frequent sessions, like 25-minute check-ins as opposed to that 50-minute session that we might be used to as psychotherapists. And sometimes it might just be checking in on how you're doing to kind of maintain that rapport. And then other sessions maybe can be longer depending on how the person's doing. I think it's, especially with this population, and I've talked about this in other talks of ours before, we want to be persistent. Of course, we want to respect individual and patient autonomy. We cannot force someone to be in outpatient treatment, but I think it's important to be persistent because there's a lot of ambivalence with folks wanting to engage in treatment. And as I mentioned, especially if there's a lack of awareness of their symptoms or how they might be impacting them, it makes sense that someone might not be all that willing to want to regularly engage in outpatient therapy. So lots of reminders, trying to be flexible with your discharge policy of, if someone no-shows 3 times, often that means an automatic discharge, but we want to be actively reaching out to our young people, checking in with them. We have found, texting a very effective way to engage with young adults. They often don't want to answer the phone and certainly don't want to listen to voicemails, finding ways to kind of meet them where they're at. One of the most important things would be finding a way to orient around shared goals. So finding that common ground. Okay, so in our case scenario, that the individual wants to stay in school and doesn't want to take a medical leave. So using that goal to orient around with them. Okay, we know that you want to stay on track with school and that's really important to you. So I'm wondering how some of these other experiences, these voices or the substance use might be getting in the way of that. Do you think it is at all? Do you think it's impacting it? You're asking really curious, open-ended questions, but you're using what you know about what the individual cares about to try to come up with some shared ground to help keep them engaged in treatment and saying I can help you with that goal. And then it can also help drive motivation for specific interventions as well. Another helpful engagement tool that is relevant to both clinicians and providers is if there's a distressing, low-hanging fruit that you can help right away, that'll give you some good kind of purchase or buy-in from the young person. So maybe they're just like, I cannot sleep. Then maybe there's no insight into the fact that, I've got voices or paranoid thoughts that are contributing to this or things, but maybe the prescriber can give them some medication that can help them sleep, or you teach them a relaxation or grounding strategy that gives them a little bit of relief and they can kind of see that relief right away. It helps them realize, hey, okay, this Dr. Sykes, she might be able to offer something to me. So maybe I'll come back next week, right? So we want to be helpful right away. And that could also be practical. That could be, I'm struggling to get this paperwork filled out for food stamps or for my medical leave or for my FMLA, or How can I get SNAP benefits? I don't really want therapy, but I just want help with this stuff. Okay, let me help you with that. I can help you with these other things. And just some important tenets throughout, like aim to be normalizing and curious. And I'm going to talk about that in different ways throughout this presentation. And as a reminder, which I think we've talked about in the family workshops and other workshops that we've had for providers, just a reminder that, if someone's actively experiencing psychosis and convinced of delusional beliefs, we largely want to avoid confrontation. We don't want to get into a tug of war or a debate about reality with someone. We don't have to agree or collude or endorse what they're saying, like, oh, yes, you're being followed by the FBI. Like, I'm not saying that you need to say that in order to develop a relationship, but you can validate their feelings because that is always, true and valid. For example, someone thinks that they're being followed or tracked. Wow, that must be really stressful. I can imagine it might feel really unsettling to not know who you can trust or to feel like you're being followed. So again, there's a way to still connect, reflect, and validate without colluding. And it's all, helping the person feel understood, which is so important to any therapeutic relationship. So additional thoughts for this engagement category. So a little bit more about this befriending approach, which is an actual approach, and it is what it sounds like. What would we do to try to be friendly, to try to develop a relationship with someone else? We wanted them to like us. We wanted to connect with them. This is an important skill for rapport building. And so different things, and everyone's different. Some folks might come into outpatient treatment right away and they're ready to roll. Maybe they've got insight into their symptoms or they're ready to start talking about what's bothering them and you dive right in. Other folks are not going to be like that. It's going to take a long time to warm up. Remember that when you're in this phase and you're talking about the person's interests, you're talking about football, you're talking about video games, and you're like, wow, we're still stuck on this, that all of that is important. And you might need to do more of that with young people with early psychosis than your typical population. Because you want to keep in mind that not all, but many individuals experiencing a first episode of psychosis may have had a period of social withdrawal prior to hospitalization or engaging in treatment. They might not have shared their symptoms or experiences with anyone before. They may still be experiencing active symptoms of psychosis that might contribute to their distrust of you as their therapist, or paranoid beliefs or voices telling them to not trust you or to not say anything. So there's a lot of things potentially going on that make engagement and opening up and connecting hard. And so we have to be patient, we have to be flexible. And so using this befriending approach upfront, but also different times throughout therapy is really helpful. So again, you want to focus on like safe topics. Again, so we're talking about sports, we're talking about interest, whatever it might be. And it helps. You want to kind of learn from them, have them tell you about something. Oh, tell me about that video game. I haven't heard about that one before. Or is that similar to this role-playing game or Dungeons and Dragons? Like help them feel a sense of mastery and learn from them genuinely. Try to also highlight strengths of theirs, help them elicit positive experiences or memories, ask them about a time that if they, are connected with family, what was a nice memory with your family that really makes you smile or happy when you think about it? Do you have a favorite pet, vacation, all these things? Of course, we want to consider different cultural considerations and things like that, but just trying to get to know the person and kind of elicit some positive feelings and kind of putting in that bank of yours, what are safe topics, what are positive things that you can later bring up should someone start to kind of pull back or be kind of overwhelmed by diving into more direct therapeutic content, like working with their delusions or paranoia or hallucinations. This is what we would call like tactical withdrawal. So maybe of course, we do have to check in on safety and we want to start talking about the experiences of psychosis in some way to start help addressing them and understanding them. So maybe you start asking questions about their beliefs like, oh, you told me you feel like you're being followed by the FBI. What's that like? Maybe I keep asking curious questions and then maybe I start to push a little bit. Like just curious, like has any part of you ever wondered if that's actually happening or if that's your mind playing tricks on you? And someone might say, maybe. And that's an intervention right there. But someone might say, see, Dr. Sykes, you're just like all the rest of them. You don't believe me. And then you're like, oops. Okay, got to pull back. Let's move off this subject a little bit. And it doesn't mean that we avoid all confrontation, but you're keeping this knowledge of things that they like, this befriending approach kind of in your back pocket to use throughout therapy to kind of help the individual feel a sense of safety, keep that trust throughout the relationship. Additional interventions within this engagement category. Folks might be familiar with the stress bucket analogy. It's one of my favorites, so I'm just going to walk you through it. This can be used for any presenting problem, any diagnosis. Doesn't have to be psychosis specific. And that's partially what I love about it, is this analogy is inherently normalizing, because it just talks about how we're all vulnerable to stress and that it comes out in different ways for us. So I'll often explain this, and if I'm in person, I'll even draw it for the individual, and I'll say, hey, okay, I want to teach you about this stress bucket analogy. Maybe you think it's silly, but I'm going to walk through it and I'm going to tell you what it looks like for me, and then I'd love to walk through what it looks like for you. And so I'll say, like, okay, so there's this idea that we all are born with a bucket. We've got different size buckets based on different things, sometimes like genetic factors, early childhood experiences. Largely the size of our bucket is out of control. And so if we think about stress as the water or the liquid being poured into our bucket, when it starts to overflow, that's when we experience things that we're vulnerable to, that are distressing to us. So I'll mention to them, for me, when my bucket starts to overflow, gosh, I get so anxious and I feel it. My heart starts racing more. My palms get sweaty. If someone was looking at me, they might notice I look a little more tense, or my partner might notice that I'm a bit more snippy with them or getting angry at them. So you kind of are asking them, you're demonstrating what it looks like when your bucket overflows. And so you want to give both like internal indicators, also talk about what it looks like from the outside. And so then I, mentioned to them, when my bucket's overflowing, there's a lot of things that can contribute to that. And I'll get into that in the next slide. The good thing is we can poke holes in our bucket and try to do things to let some of the water out or let some of the stress out. And so I'll say, for me, that might involve exercising or meditating, going to therapy, talking with a friend. So part of this, and use, if you want to use a real experience or make up one, but I think it's a nice way to be genuine. And again, normalizing that, like, we all experience stress and we're all vulnerable to different things. And so you're really demonstrating what this exercise looks like before you ask them to do it. And so I actually go into a bit more kind of psychoeducation about this. So I already shared with you, everyone's born with a bucket, different sizes. We can't always control that. There are some things that might contribute to the size of our bucket. Maybe in my family, we just got a lot of small or medium-sized buckets. Everyone seems to have anxiety or whatever it is that might contribute to the size of my bucket. And then I'll mention common stressors. And so, the stressors are what's pouring into the bucket. What's important to know about this is that stress doesn't have to just be bad things, right? There can be different types of stress, different valences, good or bad or neutral things. So common things that are stressors pouring into our bucket might be things like relationships, whether that be with our parents, teachers, significant others, friends. And, they don't have to be bad, but sometimes, okay, my parent, expects a lot of me and I really love them and I appreciate that, but it's stressful. It adds to my bucket. Transitions are a common one. And so if I know something about the individual, I might, allude to or point this out to them. Like, we know that times of transitions are really stressful for people, like making that jump to a new school year or the transition to college, other things like that. A death of a loved one, moving, so many different things are life transitions that commonly cause stress for us. You can talk about school or work. And again, I might say, for me, I love my job, but wow, it certainly adds to my stress bucket because it can, put a lot of pressure on me at times. Drugs, finances, experiences of discrimination. A lot of times you might get a little disagreement here. They might say, no, cannabis isn't adding to my bucket, Dr. Sykes. In fact, it's a stress reliever. And I might say, we've got different opinions about that. And I kind of talk about that there's like dirty or kind of unhelpful coping strategies. So I'll talk to them about this. I'll have them try to walk me through what they think their current stressors are. And then I'll say, okay, so what does it look like for you when your bucket overflows? And what are ways that you can kind of poke holes in it? If I walk through this with an individual, maybe this is what it would look like. Okay, anything that that contributes to the size of your bucket, maybe they won't know this. Maybe the family member's present for this session and they actually say, we actually do have a family history of psychosis, or maybe we're not using those words yet. And maybe we say, oh, a lot of people in our family actually do hear voices or do struggle with substance use. Okay. So maybe there's a little something there that can makes us vulnerable to certain things. Maybe they talk about their specific stressors, okay, it's October. You just went away to college, didn't you? Is this your first semester? Okay, wow, that's a big transition. Maybe, oh, you don't think so? All right. Well, I know a lot of people that think that is. And maybe they mention pressure or expectations from parents. Maybe this individual is experiencing microaggressions or more overt racism that's also contributing to their stress. And so when I get to asking them, okay, What does it look like for you when your bucket overflows? Maybe they say, oh, well, I don't know. I just go from 0 to 60. Like it's just, there's no like warning signs. It just happens. I'm like, okay, well, let's think about that a little bit. What's it look like when it's bubbling up? There's got to be some type of signs. And maybe they're able to recognize, well, my mom says I start pacing around and get pretty irritable and start kind of snapping at her a little bit. I don't know if she's right though, but that's what she always says. Or maybe again, you've got mom in the room and we ask, hey mom, do you notice anything when John's bucket starts overflowing? What do you think? And so maybe they offer that. But maybe John offers, well, I get these intense thoughts or voices, and like I don't know where they come from, but all of a sudden it's so overwhelming. Again, so this whole exercise, again, is inherently normalizing. It's helping you understand the different factors that are going into stress vulnerability for psychosis. As you're doing it, you're actually almost making like a relapse prevention plan because you're recognizing and starting to formulate what are the early warning signs that I'm going to need to look out for while I'm working with this individual and help them become attuned to look out for so they can be really active agents in their own treatment and recovery. And if families involved or other support people, you're helping them become aware of that. And then, of course, we say, because they're like, well, Dr. Sykes, like I was born with a small bucket. I've got so much stress. I'm just screwed. What am I supposed to do? And I say, no, we can poke holes in our bucket. We can also try to limit the amount of stress that goes into it. Maybe we take a reduced course load, or we try to disengage from some friends that are causing conflict, or, some things are within our control. Not everything is, but we can do some things to help ourselves. And, so then I talk to them, what works for them? Okay, talking to my best friend, therapy, maybe they talk about a specific therapeutic strategy that you've taught them. That's always a nice win when they recognize something from therapy and say it's actually helpful, but we don't always hold our breath for that. So I always start with asking the person, but if they're struggling to identify something or if I'm seeing gaps, I might ask for permission. Hey, is it okay if I add, I've known you for a couple months now. Is it okay if I add some things that I've noticed that contribute to your stress or that help you? And usually they say yes. And then you kind of put in their coping strategies. So that was a kind of a long-winded way of explaining the stress bucket, but it's just a real helpful experiential exercise that I think is a great way to conceptualize psychosis or any experience of stress vulnerability. And you can use it again with both explaining psychosis to the individual and the family member. And you can revisit it throughout therapy. A lot of this I'm going to touch on quickly, but remember the slides are going to be available for reference. Also in this early engagement goal setting stage, I just want to point out one of my favorite values exercises, the bullseye exercise. And this is where you start really talking to the individual about what they care about, what's important to them. And this can help you kind of develop this shared treatment plan, these shared goals throughout your time together. And I, always explain to them, values are different than goals. Values are actually a way of being. So that's like an ongoing action as opposed to like an end destination. So values are directions that we move in. And what's great about that is that we can always be moving in directions of our values, even if it's the teeniest little step. We can't always just immediately get to our goals, although we want to be working to those along the way. So you ask the individual, what's important to you? And you can ask them what's important to them in these different domains. So what's important to you in work and education, leisure, relationships, personal growth or health? So after you identify that, then you ask them periodically, okay, with your marker, with your pen right here, put an X on how close you feel like you are to living in line with your values in this domain. And then you kind of check in on it over time. Just another word on normalization, especially normalization in psychosis. We know that unfortunately this experience is so stigmatized, and although we're actively working both in the therapeutic setting and with the Mind Map Early Detection campaign in various ways to destigmatize and normalize the experience, we know that stigma still exists. So ways that you can normalize in the therapeutic relationship, using psychoeducation, informing individuals that experiences occur on a continuum, right? There's a range. Right? Even if we're not actively, those of us in this audience who aren't experiencing psychosis or haven't, I imagine we could resonate with the fact that, oh, wow, I could have sworn I felt my phone vibrate in my pocket, but it didn't. Or I thought I heard someone call my name. Or I thought I saw something over there that turns out wasn't actually there. Or I had a interesting belief that turns out wasn't real, right? All of these experiences can occur on a continuum, and that can help normalize things and help people feel less othered. You want to let people know actual statistics about psychosis and the prevalence of different diagnoses, of voice hearing, etc. Let people know that it can impact various identity statuses. And of course, being sure to instill hope and discuss different recovery trajectories. Some of the best ways to do this also is connecting folks with others who have lived experiences of psychosis, whether it's peers, online forums, or support groups like students with schizophrenia. This isn't going to land with everyone. Yes, there's just ways that we can be normalizing in the therapeutic relationship and the way that we talk about psychosis, but you want to check in with your client about how it's landing, because we don't want to be dismissing. For someone saying, wow, did you know that 3 in 100 individuals experience psychosis, or that's more common than you think? For some people, that might be like, oh, wow, I'm not so alone. That's great. For others, they might be like, no, Dr. Sykes, like, you don't get how bad it is for me. Like, no one else has it like me. They don't understand. And so the attempts for normalization might not land with that individual. And then you're like, oh, okay. I'm hearing you say you feel like you have a real individualized experience here that not everyone's going to understand, or even other people with similar things, that it's just not quite as distressing for them. Okay, I get that. I hear that. And you can always backpedal a little bit. So you check in, what was that like for you to hear when I said that? How did you feel about that? And then you know. That was the first kind of bullet point area. Now I'm going to touch on another big area. Okay, promoting skills. And we can do that in so many different ways, right? And as you can see here, I'm referencing various evidence-based psychotherapeutic approaches: CBT, dialectical behavior therapy, acceptance and commitment therapy, family-focused treatment, social skills treatment, social cognition interaction training. And that's not an exhaustive list, but those are some of the ones that we tend to pull from when we're trying to help someone develop skills to deal with their experiences. And so in some of the main areas of this, we've got, stress management and distress tolerance and grounding, so if you're thinking about stress management, just like that stress bucket, right? Stress management applies to everyone. It's not going to be the only treatment or intervention that someone needs, but it certainly can be helpful if we start with the basics. Like, hey, can we try to get a consistent amount of sleep? Are there things that we can take off your plate or take out of your bucket to help lower your stress? Let's work with the family on that too. Hey, like, John's going through a hard time right now where they really want to focus on school and managing their symptoms. Is there any way that we can relieve some of that pressure at home? And sometimes that's not reasonable for financial reasons or different things like that, but trying to find ways to manage stress, helping them incorporate whatever works for them. Maybe it's some relaxation exercises or adding a structure and schedule to their day so there's more predictability. It's really different for everyone. We want to teach reality testing skills, checking in with a trusted person. Hey, I just heard something over there. Did you hear that too? No? Okay. Or yeah, you did? Great. Right, these are sometimes they're like, those feel a little bit more advanced, but really just depending on where the person's at, there's a lot of different skills we can teach them to address any different symptom or experience that comes up. We also want to maybe add in social skills, problem solving, helping folks with decision making, even just doing like a pros and con list. Like, there's just so many things we can offer therapeutically that can empower an individual. I love to kind of, as I'm going through these with folks, make a coping card that we adjust over time. This is an example of what it might look like. You could put it on an index card, you could print it out and have them put it in their wallet. They could take a screenshot and have it as the background of their phone, something that's easily accessible. So maybe for John, we've got some self-talk mantras that help when they're stressed out. Okay, I've been through hard times before, I can make it through this. There my mind goes again, playing tricks on me. Social coping skills, right? So using some reality testing with a trusted parent or friend, helping them use distraction skills, physical interventions, right? Helping them take some space, maybe putting headphones on if they're sensory overloaded. Like, there's just so many different things that you can put on a coping card. I'm just going to back up to show you this slide a little bit. So this just lays out just some examples of all those different skills that we could promote. Harm reduction to substances. We already mentioned some of the other stress management ones. I think it's so essential to teach just basic grounding and distress tolerance skills. I love pulling from, the DBT manual from Marsha Linehan or the Seeking Safety manual, but helping people have just a variety of things in their coping toolkit. And again, community providers, even if you're not specializing in psychosis, you know this stuff. You do this with clients who are not presenting with psychosis, who have anxiety or depression or different types of things. And the same kind of skills are important to folks with psychosis. Sometimes a mental kind of grounding or distraction skill can be helpful, particularly if someone's just stuck on paranoid thoughts or voices that they're like, I just can't get them to quiet down. Then you have them do like a look, point, and name. Okay, I'm going to teach you this skill. I want you to look around the room, and for 2 minutes, set the timer on your phone. I want you to point and name as many things as you can and describe it. Okay, gray chair, brown bookcase, yellow tennis ball, whatever it is. And of course, you teach folks that, okay, sometimes I can do these in public, sometimes I have to do them in privacy of my own dorm room or home, but making sure that folks have lots of skills and always demonstrating them in session is helpful. Various cognitive skills, which we're going to get into more when we talk about some CBT strategies, behavioral interventions, and as I mentioned, other skills ranging from social to decision making. So now getting to that category that I call changing our relationship with our internal experiences, which can include a lot of different things. Those internal experiences could be thoughts, delusions, ruminations, various things. We want to talk about different ways of approaching that. And there's a lot of different evidence-based ways. Largely, this is where your cognitive behavioral therapies come in, and whether you're using a strict kind of cognitive restructuring model or a more third wave CBT of acceptance and commitment based or compassion focused approaches, there's a variety of different ways that you can try to address this with an individual. So we're going to walk through a couple. Diving into CBTP, so cognitive behavioral therapy for psychosis. And a lot of this training, myself and other members of the STEP team were trained in CBTP by folks at Stanford, and they kind of came in and did a year-long training with competence and kind of recording some of our sessions and reviewing them. This is just an overview of it. There's different ways to kind of become more competent in it, but I think a lot of these basic tenets can be really helpful starting place for folks. The goal of cognitive behavioral therapy for psychosis would be reducing distress from positive symptoms, and then also increasing functioning by addressing negative symptoms. We're going to focus on those positive symptoms today and try to move in meaningful and valued directions for the individual. And just to give a nod to the evidence base, CBTP has emerged as an evidence-based intervention that's recommended as an adjunct to medication management for serious mental illness. Studies have demonstrated that CBTP can result in decreased positive symptoms, improvement in negative symptoms, and improved functioning. So there's a lot of evidence to support the implementation of this specific strategy. Just walking through here, what are some different strategies you might use? And we're just going to focus on, say, delusions and auditory hallucinations. So if someone's experiencing delusions, again, we want to use some curious Socratic questioning. We want to explore and get the individual talking about their experiences so we can kind of assess and understand. And again, you're not being interrogative. You're being curious. Tell me more about that. How do you make sense of that? Has that always been like that? I guess that's not as open-ended, but you're asking open-ended questions, Socratic questioning. You're not making any assumptions. You're really just trying to be as neutral as possible. And then another intervention might be examining the evidence for and against. So maybe there's a specific thought. I think someone's following me, the FBI is following me. Okay, what makes you think that? Is it okay if we take a look at this experience together? Because it seems like this one is what you come to me about kind of every week, really distressed by the fact that the FBI is following you. Let's make a list here. I understand that you believe it, or can you tell me how much you believe that thought from 0 to 100%? Maybe they say 98%. And I was like, okay. And we kind of make a list of, what evidence do you have for that? Well, they're like, my phone always seems to know what I was just talking about. And it gives me these ads, or, that I hear footsteps, or whatever the individual has. And then hopefully they can try to identify some evidence that might not support it. So that is an intervention right there of just examining that thought or that experience. And then after, you might ask them again, okay, so now that we've talked about it, give me a ranking again from 0 to 100, how much you believe that the FBI is following you. No, I'm pretty sure they are, Dr. Sykes. Yeah, 95%. Before we just did this, you were saying 98%. Now you're saying 95%. So I know most of you believes that, but what caused that shift? That's a little bit of a decrease there. Why 95 and not 98? And maybe they say, well, when we talked about this, that made me wonder a little bit if it's just a coincidence or something. But really, I'm pretty sure this is still happening. Most of the time, you're not going to just convince someone that what they're experiencing or the thought that they're holding on strongly isn't true at all. But we want to work on increasing cognitive flexibility, generating alternative explanations. So again, you're curious, you're gentle, but occasionally the therapist over time is getting in there. They're introducing some other ideas, such as any chance it could be your mind playing tricks on you, or any other explanations for this experience that you can think of. Sounds like one of the explanations is that the FBI is following you. Any other ideas? Again, could it be a coincidence? Could it be something else? Just AI, my phone knows me, or whatever it is. and you're just trying to generate some flexibility. Again, we're trying to just reduce the distress. We're not trying to eliminate thoughts with this approach. Yes, eventually it'd be wonderful if someone wasn't holding on to a full-fledged delusion, but all of us, even if we're not experiencing psychosis, hold on to beliefs very strongly that many others might not believe. So just remembering that we're going for a reduction in distress and increasing flexibility in functioning, not necessarily eliminating the actual delusion or other psychotic experience. So some other interventions here: cognitive diffusion or decentering, teaching them this is a third wave CBT strategy of noticing our thoughts. You can teach them the fact of like, a thought is just a thought. Maybe they have a saying that they say to themselves when things start getting stressful, like, oh, there my voices go again, telling me not to trust anyone. So there's ways to kind of teach strategies that folks can kind of say to themselves that can help develop and increase that flexibility and mental space between so strongly holding on to and believing something to having a little wiggle room there and believing that it might not be completely true. And then there's other things such as behavioral experiments where you're actually testing out whether or not something is true. And those can be really powerful. And the slides will be available. If you click this link, there's an example of Dr. Kirkington, who's really one of the founders of CBTP, kind of giving an example of what some behavioral experiments might look like. In terms of auditory hallucinations, again, this isn't exhaustive, but you want to bolster coping skills. See if you can identify what's happening before the hallucinations start and try to manage antecedents differently. Maybe when someone's in a really, really loud, crowded place, they tend to hear voices more, maybe right after they smoke cannabis, maybe when they've had a bad night's sleep, they're more vulnerable to it. So if we can go upstream a little bit and figure out what's happening before and empower the person to try to manage those things a little bit differently, we can try to change the interpretation of what it's like to have an auditory experience or a voice. And I'll talk about that a little bit more in the formulation. And also, as I mentioned, you can use behavioral experiments for voices too. A couple other things I wanted to go over. I think many folks in this room, if you're therapeutic providers, you're likely familiar with basic kind of cognitive behavioral therapy and the notion of kind of Beck's basic cognitive errors or thinking errors. And so I just want you to know, although there's often like a huge list, right, of catastrophizing and all the different things, folks with psychosis tend to gravitate towards a couple different common cognitive biases or thinking errors. And so when I'm introducing this to someone too, I might have them all written out on a sheet of paper, all the different options for common thinking errors. And it, again, is normalizing. I might say, hey, this is a list of ways of thinking or missteps or whatever you want to call it, kind of thinking errors that all of us experience in some way or the other. I want to go through this with you, and maybe you could let me know if any resonate for you. Some might not, some might really hit home. Let's go through it together. But for psychosis, keeping in mind that we know folks with psychosis tend to have errors in the following areas. So jumping to conclusions tends to be one. Folks with psychosis tend to make more commonly than others. So for example, when people are laughing, individual might jump to, oh, they're laughing at me. And they just automatically go to that thought as opposed to checking out other explanations like, oh, someone's telling a funny joke. Like the mind just automatically goes there. More vulnerable to kind of blame or externalizing errors, believing that others have negative or hurtful plans, intentionalizing, so attributing negative or harmful intentions of others. So you can see how this might contribute to paranoid beliefs. For example, you might notice that your food tastes different. So instead of thinking, oh, maybe it's spoiled or the cook made it a different way or the company changed the packaging or something, brain automatically jumps to, oh, my roommate must have tampered with it or someone must have poisoned it, right? So when these errors are our go-tos, when we have these kind of thinking shortcuts, that's another way that I like to talk about them with folks. Our brains all make shortcuts to process information quickly and so we can function in the world, but sometimes they make mistakes with those shortcuts and we want to slow down and check them out again. And personalization, thinking that others are behaving negatively because of you. So of course, there's a lot more of these errors. I think you can just Google common cognitive errors and you've got a whole list of them, but I wanted folks to know which ones tend to show up with this population. So we've got 10 minutes left. I wanted to walk through kind of bringing all of this together and give you a mini formulation of cognitive behavioral therapy for psychosis. So here's kind of our basic outline for our cognitive behavioral framework. Folks might be more familiar with just the basic triangle, thoughts, feelings, and behaviors. Well, here we're adding in interpretation and the antecedent event. And I just want to remind you that anytime we're working with a client, in general, but also with psychosis, we don't want to neglect cultural factors and cultural explanations that might account for some of these experiences or beliefs of the family system or subculture that might be influencing one's interpretation of these events. It's when they start causing extra distress or they don't align with the individual's kind of family or subculture or pre-existing beliefs that we want to kind of address them. Remembering that, CBT, we're focused on reducing distress from symptoms, and we're going to focus on that interpretation. So if we're looking here, we know that emotions don't change easily, right? But it's a little bit easier to work with thoughts or beliefs or behaviors, right? If emotions were easy to change, I wouldn't really have a job. I could just, when people say, hey, feel better, cheer up, it would just work and we wouldn't have to deal with all these other things. But we know that often just saying feel better or cheer up or don't panic, don't be anxious isn't all that effective. So we need to spend some time kind of intervening in different ways. And I will kind of draw this all out for a client when I'm working with. Sometimes I don't, it depends kind of where they're at, but often I'm very transparent with what I'm showing them. Remembering that it's not always the actual experience or the event itself that is causing the distress, it's the interpretation. So for example, say there were 5 red cars passing by my house and it causes me to not leave my house because the number 5 is associated with the mafia. I know that the mafia is out to get me and I've got all these thoughts about it. You can see how that just spiraled. It's not actually that 5 red cars just happened to go by outside that caused me to stay inside and be distressed and kind of get stuck in my head. It's the interpretation. I'm going to talk a little bit about how we can try to intervene at these different levels and hopefully restructure and change the interpretation of things to decrease distress. So here's an example using this framework. Individual, the event is they hear a threatening voice. The immediate interpretation is that's my classmates talking bad about me. Behavior, they isolate, they put their phone and their laptop in the fridge, they're feeling paranoid. Some thoughts, beliefs that they're having, I'm not safe, others can't be trusted. If you dive in a little bit deeper to some CBTP, you'll kind of maybe get to some core beliefs. Maybe you know more things about this individual the longer you get to work with them, that maybe they've long-standing had the core belief that others can't be trusted. Maybe they had an early experience in childhood of abuse or caretakers not being there for them in the way that they expected. And so they've developed this belief as kind of the backdrop, the core belief, and then it comes out and it's activated during any of these events. So they easily jump to others can't be trusted. And then the associated feelings would be scared and anxious. And all of this kind of keeps going around. So what can we do? There's no one perfect answer. So what I'm trying to drive home with you with kind of all these CBTP approaches and all the interventions that I was showing you is that there's so many different levels to intervene and different strategies to try out depending on the needs of your client, the skill set that you're bringing to the therapy session. So we can try to generate alternatives, try to help them kind of question on a cognitive level, any chance this is your mind playing tricks on you? Any other explanations? We can try to intervene behaviorally. Can we test this out? Can we ask someone else, that your friend Billy over there, can we ask him if he heard the friends talking about you? Or would you ever go up to them and ask them what they were talking about? Or maybe you use other coping skills to just kind of distract away from this, some self-soothing. We can try to help them restructure the interpretation. Maybe they're saying I'm not safe because they're hearing these voices. Maybe we help them believe, okay, the voices can't hurt me. Or maybe they get to another level of understanding what this is just how my mind responds when I'm really stressed out. It interprets things this way. And again, we can always go upstream and try to manage the antecedents, thinking about substance use, sleep deprivation, overall stress. So if this is the CBT formulation for what's happening, and then after we intervene, maybe we've been able to change the interpretation and some of the different behaviors and feelings that they're doing. So this is what it might look like if you had some success with intervention. They changed the thought and the interpretation from others are talking about me to I'm hearing a voice, or I'm hearing an auditory hallucination. Of course, not everyone's going to call their symptoms that or openly acknowledge the psychosis. There's a whole bunch of different ways to kind of talk about this. This is just one example. Here's where I mentioned, behaviorally, what can they do? Okay, I know that deep breathing works for me. I'm using my coping card. I'm reassuring myself I'm okay, I'm safe. Listen to music to distract. Overall, then implementing those things, I might feel less anxious. I would do this week to week with an individual. Okay, did you try some of the strategies? All right, let's chart it out. What happened? What was it like? Let's look at this and was that helpful? What do you think? And then we're working on this together. So this is just one example of a CBTP formulation. Very quickly, I'm going to go through two other areas. Largely, these are just going to be available for your reference. So another area, cultivating a life worth living. Many folks might think, hey, with early psychosis or serious mental illness, you're not doing real therapy, which whatever that means, but diving into more exploratory therapeutic topics or identity exploration, but we absolutely are and can, and folks experiencing psychosis can engage in these topics. It might be when they're more in that kind of maintenance or recovery phase of recovery, but these things are not off limits, and they're often very important and helpful for an individual. So you want to have continued exploration of values and recovery goals. Sometimes if someone is struggling to identify what they even want to work on, I like to use the magic wand question. Okay, John, if you woke up tomorrow and you were magically unaffected by XYZ, loud voices and stress, all of your problems were solved, what would you be doing? What would your life look like? Maybe they'd say, well, I would be in school and I would be on the lacrosse team and the club. I would be out like trying to date and doing these things. And so then you use that to identify what they care about, what they might want to be working on, and say like, why wait? Let's try to start engaging and moving towards some of these things now. Other therapeutic topics that you might explore: processing past episodes. Psychosis in itself, an episode can be traumatic. Involuntary hospitalizations or various events along the pathway to care can unfortunately be traumatic or different things. So taking time to explore that with someone and help them make sense and develop their narrative around it, helping them understand and integrate this experience or potential diagnosis of psychosis into their identity, recognizing that it's only one piece of them. I've worked a lot with folks trying to help them navigate disclosure to their workplace, to friends, to family members, and kind of how to navigate disclosure in different relationships. And so there's various things that can come up and that are important to address. And some of it might involve grief and mourning of, wow, I all of a sudden got hospitalized and had a first episode in my second semester of college, and I had to drop out for a while. That is not how I expected my life to go. And even though I'm getting back on track, like I feel really sad and depressed or upset about this. Helping someone kind of cope with that, make sense of that, again, cultivate that narrative, understand, and also hold hope for their continued recovery. Lastly, again, for reference, identifying early warning signs in wellness planning is a crucial part of the therapeutic approaches to positive symptoms. We already talked about the stress bucket analogy and kind of using that as a framework, but I wanted to just put here a really great list that I use a lot. It's called The Signals of Distress from Hogarty, who wrote the book Personal Therapy for Schizophrenia. And there's 2 pages on it, but you can print these out and kind of show them to an individual or family member of all these different signs that something is bubbling up, right? Because remember I said a lot of times our clients might say, I don't know, Dr. Sykes, there's no warning signs, right? It just goes from 0 to 60, I'm fine. And then all of a sudden I'm whatever their intense symptom, they're hearing intense voices, acting on thoughts that I usually wouldn't believe, getting into trouble, having to go to the hospital. And so laying these out of like, hey, there's a lot of other little small indicators along the way. Let's figure out what they are for you so that we can detect them early, we can intervene, we can use your coping strategies, we can maybe change your medication, have an extra session, whatever it is to kind of help you be in control of your recovery and prevent troublesome relapse. That is all I have today. Here is a reference sheet of a bunch of different additional resources. Encourage folks to go to our Step Learning Collaborative site. But if you're a provider, please direct your questions to our consultation service. The link is available at ctearlypsicosisnetwork.org, and put your inquiry in, and an expert kind of early psychosis clinician or prescriber will get back to you as soon as we can to talk about your specific question for the client that you're treating. Thank you so much.